So, best way to view maxillary sinus is Waters' view. Remember Waters' view? Maxillary sinus. Waters' view, maxillary sinus. The Waters projection is optimal for visualization of the maxillary sinuses, especially to compare internal radiopacities and the frontal sinuses and ethmoid air cells. And here you can see an image. You will see an image right here of how it looks. Here you see the nasal septum, palpebral fissure, soft tissue shadow, infraorbital margin, ala of nose, zygomatic bone, maxillary sinus, foramen ovale, and the sulcus for superior posterior alveolar artery in lateral wall of maxillary sinus. On this side, we're going to be the frontal sinuses. Okay. Supraorbital canal, zygomatico-frontal suture, innominate line, inferior orbital foramen, superior orbital fissure, foramen rotundum, that can be seen up over here too, zygomatic arch, coronoid process of the mandible, and condylar head of the mandible, and the sphenoid sinuses. Next question, lipid solubility and non-ionized base. Non-ionized is lipid soluble. Ionized is water soluble. Next question. Child has pain, osteomyelitis. Staph aureus is common organism. Rarely, odontogenic infection may lead to osteomyelitis, most commonly involving the mandible. Radiographically, the bone has a moth-eaten appearance. Curettage of the area is required to remove bony sequestra and antibiotics given for at least 6 weeks, dependent on the results of microbiological culture and sensitivity tests. Test results. Next question. What do you check on bone graft? What do you check on bone graft to see if osseous integration work? Post. The options are post, instant, or pre-surgery or pre-treatment. You check post. Next, extraction sequence. The order in which multiple teeth are extracted deserves some discussion. Maxillary teeth should usually be removed first for several reasons. First, an infiltration anesthetic has a more rapid onset and also disappears more rapidly. This means that the surgeon can begin the surgical procedure sooner after the injections have been given. In addition, surgery should not be delayed because profound anesthesia is lost most quickly in the maxilla. In addition, maxillary teeth should be removed first because during the extraction process, debris such as portions of amalgam, fractured crowns, and bone chips may fall into the empty sockets of the lower teeth if the lower surgery is performed first. In addition, maxillary teeth are removed with a major component of buccal force, Little or no vertical traction force is used in removal of these teeth, as it is commonly required with mandibular teeth. A single minor disadvantage for extracting maxillary teeth first is that if hemorrhage is not controlled in the maxilla before mandibular teeth are extracted, the hemorrhage may interfere with visualization during mandibular surgery. Hemorrhage is usually not a major problem because hemostasis should be achieved in one area before the surgeon turns attention to another area of surgery, and the surgical assistant should be able to keep the surgical field free from blood with adequate suction. Tooth removal usually begins with extraction of the most posterior teeth first. This allows for the more effective use of dental elevators to luxate mobilized teeth before the forceps are used to extract the tooth. The two teeth that are the most difficult to remove is the first molar and canine. It should be extracted last. Removal of the teeth on either side weakens the bony socket on the mesial and distal side of these teeth, and their subsequent extraction is made more straightforward. Thus, for example, if teeth in the maxillary and mandibular left quadrants are to be extracted, the following order is recommended: maxillary posterior teeth, leaving the first molar; maxillary anterior teeth, leaving the canine; then maxillary first molar, then maxillary canine; then mandibular posterior teeth, leaving the first molar; mandibular anterior teeth, leaving the canine; then mandibular first molar, and mandibular canine. What is next question? Horizontal overlap of 2 to 4 millimeters of overjet. Overjet is defined as horizontal overlap of the incisors. Normally, the incisors are in contact with the upper incisors ahead of the lower by only the thickness of their incisal edges, i.e., 2 to 3 millimeters overjet is the normal relationship. If the lower incisors are in front of the upper incisors, the condition is called reverse overjet or anterior crossbite. Overbite is defined as vertical overlap of the incisors. Normally, the lower incisal edges contact the lingual surface of the upper incisor. Normally, the lower incisal edges contact the lingual surface of the upper incisors at or above the cingulum. Normally, there is 1 to 2 millimeter overbite. In open bite, there is no vertical overlap, and the vertical separation of the incisors is measured by to quantify its severity. Which is harder to anesthetize? Which is harder to anesthetize? Maxillary molar, IRP. Chronic. Again, I want to see overjet. Overjet is defined as the horizontal overlap of the incisors. Normally, the incisors are in contact with the upper incisors. The lower incisors are in contact with the upper incisors ahead of the lower by only the thickness of the incisal edges. If the lower incisors are in front of the upper incisors, the condition is called overjet, reverse overjet, or anterior crossbite. The overbite is defined as vertical overlap of the incisors. Again, well, okay, let's go back to hemisection. It's to cut molar into two, treated as two premolars. Hemisection is the splitting of a two-rooted tooth into two separate portions. This process has been called bicuspidation or separation because it changes the molar into two separate roots. Hemisection is most likely to be performed on mandibular molars with buccal and lingual class 2 or 3 furcation involvements. Okay. Which is harder to anesthetize? Maxillary molar, intraradicular. I don't know what maxillary molar IRP mean. Let me Google that pretty quick. Maxillary molar IRP. Okay, let's see. I don't know what IRP means. Okay, so I guess it is IRP is irreversible pulpitis, I guess. Well, I didn't find what it means, but okay. Okay, so next, mucopolysaccharide is Hunter-Hurler. Mucopolysaccharide, Hunter-Hurler. Mucopolysaccharide, remember that Hunter is a X linked the Hunter, and his derma has something to do with derma. Okay, mucopolysaccharide, Hunter. Mucopolysaccharide. So Hurler and Hunter syndrome, the patient have excess amounts of polysaccharide. So mucopolysaccharidosis. Hunter syndrome, mucopolysaccharidosis 2 is a lysosomal storage disease caused by the deficient or absent enzyme iduronidase 2 sulfatase. The accumulated substances in Hunter syndrome is heparan sulfate and dermatan sulfate. The syndrome has X-linked recessive inheritance, building up of glycosaminoglycan due to lack of enzyme iduronate 2 sulfatase treatment. Okay. So, exodontial maxillary posterior teeth leaving the first molar, then maxillary anterior teeth leaving the canine, then maxillary first molar, then maxillary canine, then mandibular posterior teeth leaving the first molar, then mandibular anterior teeth leaving the canine, then mandibular first molar, then mandibular canine. That is the sequence. Concentrate on using the lower third of the cutting edge for calculus removal when you're doing tooth instrumentation. If you have a pregnant lady, lay right side up. That is, what artery are you protecting? During late pregnancy, a phenomenon known as supine hypotensive syndrome may occur that manifests as an abrupt fall in blood pressure, bradycardia, sweating, nausea, weakness, and air need of breathing when the patient is in supine position. Symptoms are caused by impaired venous return to the heart that results from compression of the inferior vena cava by the gravid uterus. This leads to decreased blood pressure, reduced cardiac output, and impairment or loss of consciousness. The remedy for the problem is to roll the patient over onto her left side, so the right hip being up. If patient is laying backwards, next question. If the patient is laying backwards and going into syncope, what is being smushed? The abdominal aorta. Periapical abscess versus periapical radiolucency. Which do you do first? Endo, and then you do perio, because you cannot do a perio treatment when you have a necrotic pulp. You gotta get rid of your necrotic pulp, and then the perio will be able to regenerate itself. Neuropraxia is the least severe form of peripheral nerve injury because there has been no loss of axonal continuity. Spontaneous full recovery of nerve function usually occurs in a few days or weeks. Neuropraxia. Again, neuropraxia is the least severe form of peripheral nerve injury because there has been no loss of axonal continuity. Spontaneous full recovery of nerve function usually occurs in a few days or weeks. Now, 3 types of peripheral nerve injury. A, neuropraxia, which is when the injury to the nerve causes no loss of continuity of the axon, or endoneurium. Example shown is implant placed in inferior alveolar canal compressing the nerve. Now, the next type of peripheral nerve injury is axonotmesis. It's injury to nerve which causes loss of axonal continuity but preserves endoneurium. Example shown is overly aggressive retraction of mental nerve. Next, neurotmesis. Injury to nerve causes loss of axonal and endoneurium continuity. Example is cutting of inferior alveolar nerve during removal of a deeply impacted third molar. So the worst one is neurotmesis. think neuromesis. It has to do with the whole nerve. The B is axonesis. Only axonal continuity is damaged, but the endoneurium continues. And the least damage is caused in neurapraxia. Injury to nerve causes no loss of continuity of axon or endoneurium. Neuromesis is the most severe type of nerve injury, involves a complete loss of nerve continuity. Prognosis for spontaneous recovery of nerves that have undergone neuromesis is poor. The band and loop. The bands show the cemented with a luting glass ionomer as a protection against caries and the appliance reviewed regularly. Again, band and loop. Bands should be cemented with a luting glass ionomer as a protection against caries and the appliance reviewed regularly. This is for a band and loop in ortho. Okay, band and loop. Band and loop. The bands should be cemented with a luting glass ionomer as a protection against caries and the appliance reviewed regularly. Next question. Which least likely to have hepatitis B? Which is the least likely to have hepatitis B? 1. Cafe workers at hospital. B. Down syndrome. And B. A diabetic. Which one is the least likely to have hepatitis B? Hepatitis B, let me see. Let's see what corrected Golden says. Hepatitis B. Workers that are the least risk for hepatitis B are food service, Down syndrome, or drug addicts. That's another question. I don't know. I don't know. Hepatitis B, which one is the most? According to the papers I have, hepatitis B is the least likely to have it is a diabetic. A vaccine to immunize recipients against a vaccine to immunize recipients against wait. A vaccine to immunize recipients against hepatitis B virus is available. 3 doses are given to confer immunity, an initial dose followed by a second dose at 1 month and then a third dose 6 months after the first. Since hepatitis B virus is highly infectious, all dental personnel should be vaccinated against hepatitis B. Okay. So, DFDBA is osteoinductive. The ability of the graft to contain molecules that convert neighboring cells into osteoblasts. DFDBA, dried freezed. I don't know what that means. And FDBA is another one. So DFDBA has a higher osteogenic potential than FDBA and is therefore preferred. So DFDBA has a higher osteogenic potential than FDBA because is osteoconductive. The ability of the graft to contain molecules that convert neighboring cells into osteoblasts. And FDBA is only the osteoconductive potential of graft material to serve as a scaffold that favors outside cells to penetrate the graft and form a new bone. This all in must be 260. OKC is aggressive, and histology a thin layer of parakeratinized and orthokeratinized stratified squamous and posterior mandibula. Treatment requires aggressive and complete removal of the lesion. These patients should be evaluated for nevoid basal cell carcinoma syndrome, which is Gorlin-Goltz syndrome. Nevoid basal cell carcinoma syndrome, Gorlin syndrome, is autosomal dominant. Multiple basal cell carcinomas of the skin, odontogenic keratocysts, posterior in the posterior mandibule. Intracranial classification in falx cerebri and frontal bossing, and rib and vertebral anomalies. Consequently, it is recommended that there be at least 3 millimeters between the gingival margin and bone crest. This allows for adequate biologic width. Well, this is something different. This is not about nevoid basal cell carcinoma or OKC or Gorlin. It's another subject. Consequently, it is recommended that there be at least 3 millimeters between the gingival margin and bone crest. This allows for adequate biologic width when the restoration is placed 0.5 millimeters within the gingival sulcus. In the case of caries of tooth fracture, in case of caries and tooth fracture, to ensure margin placement on sound tooth structure and retention form, the surgeon should provide at least 4 millimeters from the apical extent of the caries or fracture to the bone crest. 4 millimeters. Material least to do impression with is an irreversible hydrocolloid polyether. Apexification is the most common complication. Is cervical crown or root fracture, because in apexification, the most common complication of apexification is cervical crown or root fracture, because the cervical portion of the tooth is very thin and may fracture easily. Next, calcified canal. What do you do? Refer. When is it okay to do a temporary fixing on patient on an emergency? How did you get a child acting out to act favorably? Let them watch another child behave. Called modeling strategies. Cancer translocation p53 gene. Hepatitis B virus. Etiology. The disease is produced by a highly infected virus known as the Dane particle. The intact virus consists of an inner core antigen, HBsAg, and an outer coat surface antigen, HBsAg. The risk of transmission is 30% after percutaneous injury from an infected patient. As little as 1 times 10 at minus 8 milliliters of blood can transmit the disease. Diagnosis. Hepatitis B virus is diagnosed based on a physical examination, medical history, and blood tests. Hepatitis B virus blood tests include hepatitis B antigens and antibodies, and hepatitis B viral DNA, which detects genetic material, the DNA, from the hepatitis B virus. Again, the diagnosis is based on a physical examination, medical history, and blood tests. Hepatitis B virus, the blood tests include hepatitis B antigens and antibodies, and hepatitis B viral DNA, which detects genetic material from the hepatitis virus. Hepatitis B virus. It's prevention. A vaccine to immunize recipients against hepatitis B virus is available. 3 doses are given to confer immunity: an initial dose followed by a second dose at 1 month, and then a third dose 6 months after the first. Since hepatitis B virus is highly infectious, all dental personnel should be vaccinated against hepatitis B virus. So what we were talking about, freeze-dried bone, which is allograft. Freeze-dried bone allograft. Several clinical studies by say that 50 to 67% of the defects grafted with freeze-dried bone allograft, and 78% of the defects grafted by freeze-dried bone allograft plus autogenous bone. Okay. The bone fill exceeds 50 to 67%. So, however, is considered an osteoconductive material, whereas the calcified freeze-dried bone allograft is considered an osteoinductive graft. So one is osteoconductive, and the other one is, and the longest name, the calcified freeze-dried bone allograft. So they're both freeze, they're both dried, both bone allografts, but the calcified is considered osteoinductive. Laboratory studies have found that the calcified freezed dried bone allograft has a higher osteogenic potential than freeze-dried bone allograft, and is therefore preferred. So the decalcified is preferred. Decalcified in periodontal defects result in significant probing depth reduction, attachment level gain, and osseous regeneration. The combination of decalcified freeze-dried bone allograft and GTR has also proven to be successful. However, limitations of the use of decalcified freeze-dried bone allograft include the possible, although remote, potential of disease transfer from the cadaver. So the freeze-dried bone allograft is osteoconductive, has a potential of graft material to serve as a scaffold that favors outside cells to penetrate the graft and form a new bone. And the decalcified freeze-dried bone allograft is osteoinductive, the ability of the graft to contain molecules that convert neighboring cells into osteoblasts. Next, OKC, odontogenic keratocysts, is an important entity to differentiate from other odontogenic cysts because of its potential to be aggressive. It is the most likely to recur. Odontogenic keratocysts can be seen at any age but are most often diagnosed in patients between 10 and 40. They occur most commonly in males within the posterior mandible. Radiographically, odontogenic keratocysts present as well-defined unilocular and multilocular radiolucencies. Histologically, the cyst lining consists of a thin layer of parakeratinized or orthokeratinized stratified squamous epithelium with a prominent basal cell layer and a corrugated appearance of an epithelial surface. Treatment requires aggressive and complete removal of the lesion, as recurrence rates for inadequately removed lesion can reach 60%. Multiple OKCs may occur. The patient should be evaluated for nevoid basal cell carcinoma syndrome or Gorlin syndrome. Now, a nevoid basal cell carcinoma is an autosomal dominant inherited condition that exhibits high penetrance and variable expressivity. The syndrome is caused by mutations in patched PTCH, a tumor suppressor gene that has been mapped to chromosome whatever. Approximately 35 to 50% of the affected patients represent a new mutation. The chief components are multiple basal cell carcinoma of the skin, odontogenic keratocysts in the posterior mandible, intracranial calcifications, which is calcification of falx cerebri and frontal bossing, and rib and vertebral anomalies. Many other anomalies have been reported in these patients and probably also represent manifestations of the syndrome. The presence of Gorlin syndrome is estimated to be of 1 in 60,000. Okay.